Good morning, ma'am, and good morning, ma'am. Morning sessions are always a challenge, especially on weekends, Saturday and Sundays. But anyways, it's great to have, even if we can drive in a message to one person, it's I think, a job well done. The reason why we delayed is because we have two of our speakers yet to come. They are on their way, Dr. Manpreet and Dr. Mohita. So thank you all for coming. Today we'll be speaking the ICs on optics and mathematics made easy for a cataract and refractive surgeon. Special focus on certain conundrums, in terms of what imaging do we use, what scenarios do we use in imaging. So a wonderful series of talks ahead of us. I'll be speaking on tomography and epithelial mapping made simple. Okay, so the challenge I think lies in the fact that we have a lot of instruments. Some centers might have a Scheimpflug, some centers might have a slit scanning, but I think the general consensus in terms of which tool do we use, at least in refractive practice, it is the Scheimpflug. Now, why is it the Scheimpflug? It's not about just the cost. The fact that it delineates posterior elevation very well is important, and that also has a role in planning cataract surgeries better. And how does that happen and how do we proceed with that is what I would go in. And I think it's understood now that cataract is a refractive surgery. And it's not only about the premium patients, it's even a simple cataract surgery. You need to optimize outcomes. And that's where the role of tomography into our cataract practice is something which is very important. Now, why a tomographer and how do we utilize tomography in our cataract practice is something which is important to understand. Now, there are four important effects. When we are looking at curvature, it's just not putting in K1, K2, and looking at the pachymetry, etc. It's about optimizing which type of maps we use. Now, if you're looking at any sagittal curvature map or an axial curvature map, there is a concept of refractive effect. What is refractive effect is ideally, the radius of curvature in a sphere is equal at all quadrants, or overall it's uniformly equal. By that logic, curvature also should be equal, right? So if it is 43 in the center, it should be 43 in the periphery. But why does that not happen is because of an effect of something known as spherical aberration. Now, the understanding has changed in IOL formulas is because a normal scenario, anterior and posterior surface of the cornea is actually constant, posterior surface being 82% of the anterior surface. So thereby, in scenarios where it's a virgin eye, it does not make a difference as to what value you take or what reading you take. But in scenarios such as a post-refractive patient, this ratio can get altered. So that is something we need to remember. The refractive index, traditionally Placido or any keratometers use a refractive index of 1.3375. But actually it is 1.332. I mean, you don't need to remember the values, but what you need to remember is that there is an inbuilt correction in these IOL formulas to factor that change in the refractive index. And also the location of the principal planes. Though it is not very significant, the principal meridia of the anterior surface of the cornea is in fact different from the posterior surface of the cornea, and how it actually is extrapolated to a practice is something which I'll just speak to. Now, this is, I think, a commonly used map which you see. This is the 4 map which you see on a pentacam. Any Scheimpflug tool will have the classical 4 map, which gives you the curvature, which gives you the elevation, anterior elevation, posterior elevation. It also gives you the values in terms of keratometry. But what keratometry value do we use? I know this is where the concept of sim K or simulated K comes into being. Now, if you look at the central 3 millimeter zone, I don't know if you can see. Yeah, if you look at the central 3 millimeter zone, the average of the keratometry values here is what is normally taken. Now, the challenge is the fact that you need to understand that the keratometry values taken are not, it's not a simple average. What a tool or any tool like a pentacam does is they look at just certain amount of points and extrapolate the remaining. So if you get a 47, it actually may be just 46.98 or a 47.26, but just for simplification they extrapolate it, and that 0.2 or a 0.1 diopter change or a difference generally does not make a difference in the outcomes when you're looking at refractive surgery maps. So I'll try to simplify what maps there are. Now, whenever you're looking at a sagittal curvature map, you need to understand that, if you see, these readings are actually the same throughout. Why is that so? Is because this map does not consider or take into the effect of the refractive effect which I spoke about, is which is a spherical aberration. So the first mistake people do is axial and sagittal curvature maps cannot be used interchangeably. Sagittal curvature maps consider curvature, but consider curvature without spherical aberration, and therefore you get the keratometry which is kind of uniform from the center to the periphery. The refractive power map, on the other hand, incorporates the effect of spherical aberrations. So if you see, the central values are different from what you see as you go towards the periphery. So that is something you need to remember. The true net power map. So these are the maps. If you're talking about the sagittal curvature, you're talking about the refractive power maps. In practicalities, these are not something which we use. To summarize it, we generally use SIMK or use EKRs, and these are the ones or the keratometry readings which are finally put into IOLPAR calculations, simply because of the reasons which I will elucidate now. Now, the true net power looks at the anterior surface of the cornea as well as the posterior surface of the cornea. I spoke about the fact that ideal scenarios, anterior and posterior ratio is constant, and it can change in scenarios like a post-refractive surgery. So in those IOLPAR formulas, this practicality does not hold true. But the challenge is because it's using a refractive index of the cornea, refractive index of the aqueous humor, what invariably happens is this cannot be incorporated into IOLPAR formulas because they're using a refractive index of 1.3375. So, morally we are talking about true net power being good enough, but actually in practicalities we don't use it. EKR is a wonderful option. I was speaking about EKR options which are seen on the Pentacam. What is an equivalent K-reading map is the fact that it gives you the range of the dioptric distribution of the keratometries over various zones, 1, 2, 3, 4.5, 6. What is also useful is that it could be used in formulas because it factors into the refractive index of 1.3375, and also it calculates for an adjustment for both the anterior cornea as well as the posterior cornea. So that is something which is very important. So I spoke about those 4 effects: refractive index, refractive effect, anterior posterior, and the location of the principal meridia. Overall, EKR kind of looks into it. So if you see people planning multifocal IOLs, you look at an EKR, look at the EKR in the 4.5 millimeter zone, look at the distribution of the keratometry. So if you see, this is not a very widely distributed keratometry, so it is a compact, not something which is irregular, and these patients would do well. So why do we need it in such scenarios? Is because one is obviously planning multifocal IOLs. The second thing is, even for planning a simple case, it need not be a premium IOL. Optimizing outcomes in terms of post-operative quality vision is also important. So you get a patient who maybe has a focal scar. What you could do is look at EKR, the distribution of the EKR over the 4.5 millimeter zone, but also to summarize, there are some other aspects of values which are seen. There's something known as EKR 65, which is actually 65% of the mean values. There is something which is known as the global mean EKR, which gives you an average of the EKR. So what happens is, in a regular cornea, the EKR, the mean EKR as well as the EKR 65 generally tend to be almost or very less than 0.5 diopters, and that is what is important in these cases. The total corneal refractive power map again uses ray tracing. It accounts for, I spoke about refractive effect, inclusion of the anterior and posterior surface. It also looks into the effect of the principal meridia both in the anterior and the posterior cornea. But again, more realistically, it generally does deviate from the SIMK, and therefore it cannot be used. So I'll be going into aspects of epithelial mapping before I kind of summarize what I spoke about. So I'll just try to cut down for want of time. Now, epithelial mapping is a challenge. Why is it a challenge? Is the fact that topographers do not factor for epithelial changes. If you're looking at a pentacam, they assume that epithelium is irregular, and that invariably can be a confounder. Yes, okay, can be a confounder. So it's important to understand that epithelial mapping tools such as MS39. I know not all of you will be having an MS39. Any tool, it need not be an MS39, an anti-segment OCT. It's very important to incorporate this into your existing practice. Okay, so you get scenarios where corneas appear to be suspicious. You get an area which is focal steepening. It would be prudent to do an epithelial mapping in those scenarios, simply because sometimes patients do present with ghosting or glare or visual disturbances, and you get a picture such as this. In fact, the epithelium was the culprit. If you see the area, of the steepening coincides with the focal area of an epithelial hypertrophy. Now, another aspect is also in terms of planning for surgeries. One is preoperative epithelial mapping. The second thing is postoperative outcomes. So, always treat ocular surface. Epithelium is a very good indicator for the ocular surface health. That is prior to planning. Post-operatively as well, patients coming with glare, halos, the concept of epithelial regression. Therefore, epithelial mapping is something which is very important in those scenarios. Pseudo regression. So you get patients who are keratoconic. They have 2 time points. Sometimes you see pachymetry is stable, but there is steepening. In those cases, it's actually not true progression. It could be epithelium remodeling, which could be one of the causes in such cases. So to summarize overall, tomography is important not only for refractive surgery. You need to customize your use for tomography in IOL practice, in cataract surgery. Epithelial mapping is a useful tool, not only in refractive surgery again, even in outcomes post, cataract or post refractive surgery. It's important to at least have one device, any ASOCT, to kind of simplify or help us in this. So we'll move ahead with the course. We'll speak. Next speaker is Dr. Pooja has an IC at the same time. Therefore, my colleague Dr. Reshma will be speaking on unhappy patients. So a lot of cases, in refractive surgery, you get patients coming in with 6/6. They have good vision, but they're not happy. And how do we actually approach these patients? Though it might form maybe 10% of our refractive surgery practice, these are the patients who take a lot of chair time. So it's important to understand as to what could go wrong and how do we approach these patients. So Reshma.